Excellent. Let's give a nice big round of applause for Michael Ashbolt, one of our returning presenters. Let's hear it for Michael.
Thanks, mate. Cheers. Hi, everybody. My name's Michael. I'm an intensive care specialist from Hobart, and I basically work for the retrieval service half-time and a combination of intensive care and now a trauma staff specialist job at the Royal Hobart Hospital. We've just started up a program of having an inpatient trauma service, so having a dedicated team that looks after all of our trauma patients, and so we're just sort of finding our way with that, like many other hospitals around Australia. So I'm going to talk a little bit about traumatic coagulopathy, and a little bit more about traumatic bleeding and traumatic resuscitation, and give people a bit of a background of the situation. We'll just talk first of all about its importance, really. So obviously, traumatic hemorrhage contributes significantly to overall mortality in trauma and contributes to a lot of the traumatic deaths that we see around the world. In our EDs, a significant number of patients receive massive transfusion for blood loss and hypertension in trauma. Not all have massive blood transfusion needs, but it's something that's done very frequently. Uncontrollable torso hemorrhage remains rare, which is very good, but that and requiring an urgent laparotomy, although rare, involves a very high mortality. And those are the patients that we really look to try and make a difference with treating their traumatic hemorrhage appropriately. Over the last 10 years or so, there's been lots of trauma packages of care, very much like sepsis, and there's been lots of interventions that we think overall have gradually improved outcome, the individual components of which we're still working out their contributions, but there's certainly been a gradual improvement in traumatic outcomes over time. As things have improved, there's been new modes of death that have occurred and that we've been finding out about. So we're seeing a lot less early deaths in the first 3 to 24 hours from traumatic coagulopathy and ongoing bleeding, and much less ARDS, much less compartment syndrome. And we're seeing other problems at that 24 to 48 to 72 hour mark, where we're seeing prolonged myocardial stunning and complex shock states that involve both both hypovolemic shock with trauma, but also distributive shock and cardiogenic shock as well. And then secondary vascular failure and multi-organ dysfunction. And then late in the course of people's illnesses, at the sort of 2-week mark or so, we're seeing many deaths from immune suppression associated with this chronic inflammation of trauma. So that's sort of background and the importance of the topic. I mentioned that we've seen improvements in mortality over time, and this is an article from Karim Brohi, which is one of the major investigators from London. And they've looked at that between 2009 and 2015 with similar patient cohorts in terms of illness severity. And they've seen, I'll try the pointer, a significant reduction in pre-hospital deaths due to improved EMS care, amongst a number of other things. An increase in the first few hours of deaths because there's lots more very, very unwell people making it to hospital. Much less death from ongoing bleeding in that 3 to 24 hour mark from acute traumatic coagulopathy. And then this sort of cardiogenic shock state and distributive shock state where there's this increase in deaths, but overall, reassuringly, reduction in deaths over time. So that you can see that actually it has been some improvements with trauma care. And really that's come down to these modern trauma principles that we've been following, the contribution of which is very difficult to tease out, but everyone knows that we try and stop bleeding, rapidly transport patient to hospital. In the hospital, there's a very big emphasis on early damage control surgery, so only doing the minimum amount of surgery that you need to. We're increasingly using both interventional radiology to stop any arterial bleeding, but also minimally invasive surgical procedures, both early in the illness and also late for things like pancreatic injury and things like that. We're trying to do as little invasive operating as possible. Hemostatic resuscitation, which I'm going to spend a bit of time talking about. Permissive hypertension, which is somewhat controversial. And then intensive care has gradually improved over time as well, We've improved our organ support, renal support, respiratory support have both improved dramatically. And even things like ECMO now for trauma patients is coming along to improve those patients that have profound cardiac failure in the first sort of 24 to 72 hours. And also ECMO for lung injury as well in trauma is becoming more and more popular. Interestingly, the background to some of these interventions is very much animal, sort of common sense, animal study based, and large observational trial based. There's been very few randomised controlled trials until recently into any of these interventions, which is a sort of unusual in that most of our other practice in intensive care and ED and paramedicine is evidence driven largely by randomised trials, but it's very difficult to conduct those in the setting of trauma, which we'll talk about later on. So with the limited research that we do have, there's a large need for guidelines based both on expert opinion and on the limited evidence that we have. There's two important ones to know about at the moment. The European guidelines here, 2019, I think, and they're really nicely written and cover all of the complicating things to do with traumatic bleeding and coagulopathy. In Australia, we had quite a delay in revising our guidelines. It was 2016 was the last critical bleeding guideline from the National Blood Authority. It's actually just been redone only in the last few, sort of 6 months. There's now a new version of critical bleeding and a new major hemorrhage algorithms, recommendations and things like that. So that's also a really good reference point after the talk if you want to get some more information on Australia-specific stuff. I mentioned before that there has been some randomised controlled trials. I'm going to talk about a few of them. Interestingly, in the last two years, there's been lots and lots of clinical trials that have been published, which is sort of the prompt for this talk, because not necessarily everybody will have know about what's been published in the last 2 or 3 years. We're going to talk a little bit about stopping uncontrolled torso hemorrhage with REBOA, or endovascular occlusion of the aorta. We'll talk a bit about endothelial injury and traumatic coagulopathy, preventing hyperfibrinolysis with TXA. I think many of people in the room will have been involved with the PATCH trial and will be aware of other trials in that area. And talk a little bit about viscoelastic testing as well. I think it's important to recognise that microcirculation is playing an increasing role in the pathophysiology of all of these illnesses, be they sepsis, cardiac arrest, ischemia reperfusion injury, and trauma as well. And we're recognising the importance of the microcirculation over time. So I'm going to talk a little bit about that and a little bit about the future of clinical trials in trauma, because they are hard to conduct and we are having a lot of, I suppose, negative trials, you would call them, but trials that don't show a difference between the intervention arm and the standard care arm. All right, so onto the slightly more, I thought I'd do this at the start of the talk rather than at the end because people tend to fall asleep a little bit, but endothelial dysfunction, I find it very interesting. I spoke about it last year for cardiac arrest as well. And it's got an increasingly important role in the pathophysiology of many illnesses. Cardiac arrest, trauma, sepsis. We're finding out that it's all about the endothelium, and we need to look after the endothelium and treat it when it's had damage. So basically this is a capillary, or actually slightly bigger than the capillary, but you have this hairy layer on the inside here that's sort of proteoglycan, sort of hair-like structure that separates out the blood from the pointer's quite tricky. So this is the endothelial cell layer right where the middle of the light is there, and the glycocalyx is there. And so you can see, compared to the endothelial cells, it's actually quite thick, and it provides the lubrication for the blood to flow, and it prevents all the inflammatory platelets and other clotting factors from reaching the endothelium and being activated. In severe hemorrhagic shock, we see shedding of the glycocalyx, so it gets sheared off. The small yellow illustration there is the sheared off glycocalyx. We also see loss of the adhesion junctions, increase in permeability and leakage of water and protein outside of the capillaries. And so you can see in your burns patients, trauma patients, you will see them in ICU and they will be 10 kilos heavier, puffy, lots of fluid, even fluid leaking out of the skin as well, potentially at some points. And those are the patients that have vascular failure as a result of this hemorrhagic shock, and they've sheared off their glycocalyx, they've got leaky capillaries. Following on from that, we wonder, well, talking about the microcirculation, if we're looking after the endothelium, what about the microcirculation, and is that important as a secondary thing? So often in these patients, we're in the ICU, we're measuring their heart rate, their blood pressure, we're giving them fluids, we're giving them vasopressors, we're monitoring their cardiac output, we might give them a fluid bolus if their cardiac output's low. So we're optimising their macrocirculation, but we're not really looking at the microcirculation. And we've actually found out recently that the microcirculation has a much tighter correlation with organ dysfunction and outcome than the macrocirculation. And there's many patients we might optimise their macrocirculation, but find they go on to develop organ failure despite that. And so why might that be the case? Well, there's a number of different reasons. Certainly, you may have parts, if you've got an intact macrocirculation, good cardiac output, there'll be areas in the body where the microcirculation is different, so the heterogeneity to the circulation. You might find that you've got hemodilution and that we're running at a hemoglobin of 70 in ICU for these patients, but in actual fact at the capillary level that's not supplying enough red blood cells over time to meet that capillary bed's needs. Venous congestion is also important, and edema from all this fluid leak is important as well. So increasingly the microcirculation is playing a role in ICU. Any talk about traumatic coagulopathy wouldn't be complete without talking about the lethal triad of trauma. I've got a slightly different opinion on that than a number of people. And I think a lot of it's been slightly misinterpreted in that you've got your variables of acidosis, hypothermia and coagulopathy, and these have all been derived as increasing mortality in observational studies. And it's much more of a marker of severe illness and severe shock than they are of actually treatment points. So there's not much evidence to support the fact that if you treat a coagulopathy or you treat a hypothermia, or if you correct the acidosis, it actually makes a difference to people's outcome. It's a marker of illness severity. And so the more recent models have moved away from this triad of trauma, and it's a slightly more complicated diagram, but it gives a good insight into how this actually comes about. So like sepsis, like cardiac arrest, it's about the endothelium. If you have a pre-existing conditions, age, particular genetic makeup that makes you more susceptible, and then you have a trauma, I'm working my way down the diagram here, you have tissue damage and hemorrhage, which are initiators of a shock state, and also flood the body with all these antigens to set off your inflammatory system. And then you develop this systemic endotheliopathy that involves the glycocalyx, it involves your body heparinizing itself, involves platelet activation, and then it also involves this hyperfibrinolysis process, which is part of the acute traumatic coagulopathy. So that's what drives this underlying problem rather than the actual hypothermia or the acidosis, which are all secondary problems. Then there's a few trauma-associated factors. So you might lose some clotting factors as you're bleeding these products out, your blood out. You might consume some clotting factors as you're trying to form clot. And then some resuscitation-associated factors. So you add lots of saline, you might dilute your clotting factors. You might become cold from being in the environment, and you might develop a significant acidosis, all of which can make things worse, but aren't the initial driver of the problem. And that's when you end up with traumatic coagulopathy. And as we've been working on trauma and finding out that we're following this pattern of pathophysiology and treating the right points, I think we're getting less and less traumatic coagulopathy in our patients. This is just a little bit slide explaining the hyperfibrinolysis process. I won't dwell on it for too long, but essentially we're having high levels of activated protein C that then activate plasminogen into plasmin, which then dissolves the fibrin clot. We see elevate. Some of the original work we've known about this for some time, and that activated protein C levels go up and fibrinogen levels go down in acute trauma. And you can see here that it happens quite late. So on admission, they're fairly normal, and then at 8 hours, if you don't replace fibrinogen, you end up with very low levels, which we'll talk about later on in the context of some clinical trials. So keynote clinical trials in trauma in the recent times, I've categorised them into things that are about some of our major trauma processes, so stopping the bleeding. So all of you guys here are aware of the use of tourniquets, we're aware of the use of compression bandages, procoagulant, clotting, dressings. There's a few initiatives in the field that are looking at trying to stop the bleeding at the scene. And there's been a significant study based around the PROPER trial, which we'll talk about, that found that for every 15 minutes that you delay stopping the bleeding, there's actually a significant increase in the overall mortality rate. So and it's sort of exponential over time as well. So the quicker you can stop the bleeding, the much better it is for the patients. So coming to that, when talking about uncontrollable torso hemorrhage, so that's bleeding in the sort of chest, but usually below the diaphragm, in the abdomen, in the pelvis. There's an invention called a Roboa device, which is a catheter that's inserted into the femoral artery and threaded up into the aorta, and then an inflated balloon, and essentially you block the aorta from the inside. And trauma surgeons have been doing this for a long time from the outside, either with external compression or doing a clamshell thoracotomy and actually pressing on the aorta and occluding it and then resuscitating the patient. But that's obviously very invasive, it takes some time to do, needs an operating theatre. Can we improve things by just blocking the aorta proximally to where the arterial bleeding is? This is the catheter that's been used, and there's a number of different brands as well, but essentially it's the same as any interventional catheter and can be put in fairly easily. And it's positioned depending on where you think the bleeding is coming from. So if you think it's a liver laceration, renal laceration, splenic bleeding, you position it in zone 1, which is above the diaphragm, sort of in, we can see here around this little level in the descending aorta. If you think it's pelvic bleeding, you can position it in zone 3 here, which is obviously less of the body becomes ischemic the lower you position it down. And it was very, has come with a lot of fanfare, both for use in hospital, but also in the use in some HEMS services. And so London HEMS were using it for some period, and even in Melbourne as well, it was being used as well. And so there's a lot of fanfare involved, and like most things that involve helicopters and trauma and surgery, there's a lot of people very interested in seeing this succeed. And on the face value, it seems to make sense to stop bleeding and then fix the bleeding once they get to hospital. So there's a trial done called the UK Roboa trial, done in the UK, multi-centre randomised controlled trial of Roboa or standard care. It's done in the ED. Lots and lots of training involved, lots and lots of sites, and quite a long trial in terms of recruitment. So it was published in JAMA just last year. Small numbers, so 62 men, 28 women, 16 major trauma centres, so a lot of training, and lots of sites only had a couple or a small number of patients. And they actually found that the patients that got Roboa in the ED had a higher mortality than the patients that got standard care. And many thought that was due to just delays involved with implementing the Roboa in the emergency department. And so it was found that an increased risk of mortality, which is one of the only randomised controlled trials recently that's found a significant difference, the opposite way to what they were expecting. So that sort of put the brakes on things slightly. And but there's a given part of this talk was to outline the difficulties of this research in trauma, and you're doing a very high stakes, difficult intervention in multiple study sites that haven't done rubella before in the ED. So I think it's a very difficult intervention to test in that fashion versus doing it in a single centre that does a lot of rubella already, and it's done by maybe vascular surgeons or something like that. So I think it's, this is the overall conclusion, was that it increased mortality, but it was underpowered, limited experience centres, and they had very long occlusion times and used complete aortic occlusion. If you imagine, if you want to reduce bleeding, you might be able to just block the aorta for 10 minutes, let a clot form, then let the balloon down and reperfuse the rest of the body. It may not need to stay up for an hour or 2 hours, and that's certainly the way rubella is moving into the future. So the consensus statement is the balloon hasn't popped. It's still a possible treatment that's going to happen over in major centres, but we'll have to wait and see exactly what type of rubella and what type of whether we use complete occlusion or partial occlusion rubella into the future. All right. So moving on to fluid resuscitation, this probably has a little bit more relevance to everybody in the room. So questions of what fluid might we use for trauma resuscitation, how much, and what about in the pre-hospital setting? So what resuscitation fluid, do we use whole blood? Do we use component therapy, which is what's done in Australia and New Zealand at the moment? Packed red blood cells, plasma and platelets? Or do we use normal saline, which is by far and away what we use in the pre-hospital setting the vast majority of the time? So interestingly, none of this is, if you looked at studies that ask the question of who receives what around the world, the resuscitation fluid choice is largely dependent on your geography rather than anything else, and certainly not on pathology. Most of the interventions have not been tested in clinical trials. Certainly normal saline is very rarely used as a comparator in the current clinical trials. But there's a necessity to start to do some of this sort of stuff. We need to actually look at the physiology, look at the animal basic science, and then do a lot more single centre studies where we actually put the intervention through a rigorous research program where it's actually tested, as opposed to testing it in a very heterogeneous population of lots of different patients and lots of different sites. And we might need to look at a precision medicine approach, which we'll talk about shortly. This is a study that was published last year, and interestingly, you wonder why are we still doing porcine research comparing whole blood to component therapy to FFP to normal saline. And it's interesting that it's quite surprising we haven't got human clinical trials that look at this, that answer this question, and we're still doing animal research. But interestingly, I think it still has a large amount of relevance for us, and it's one of the only studies recently that actually puts these things head to head so we can see what actually happens. And I suspect that we're probably a lot more similar to pigs than what we think. So you can see here, this reaffirms some of our background teaching on physiology as well. So this looked at pigs that got injured, like big hematoma, liver laceration, 30% blood loss, and then gave them bits of fluid over time. And the bits of fluid that they got was specifically what was prescribed. So if you use just normal saline to maintain your blood pressure, you use a lot more fluid, 3 times more than you would use with blood products. And your hemoglobin goes down significantly as well. But interestingly, your delivery of oxygen actually stays reasonable because your cardiac output increases and to compensate for the lower hemoglobin. And this is the survival curves for these animals. So they did quite a few animals, and the animals that got packed red blood cells and FFP, or fresh whole blood, all survived the 8 hours. The animals that got no treatment at all died, and the animals that got saline, a significant 25% of them died by the end of the study period. So, look, there is a fair rationale to using blood and using whole blood, particularly in this cohort for trauma resuscitation. So, component transfusion ratios. This is another sort of commonly asked question. The big landmark trial for this was the PROPER trial in 2015. and this looked at 680 patients. And there's been a whole lot of follow-on studies with this as well that are quite interesting. But the primary study looked at plasma platelet red blood cell ratio of 1 to 1 to 1 versus 1 to 1 to 1, 1 to 1 to 2, where you got more red cells than you did plasma and platelets. They found a mortality difference that wasn't significant statistically, but they also found fairly convincing earlier hemostasis and a reduced death by exsanguination. They did use more FFP and platelets, but there was no complications of that. So sometimes you think of if you use more FFP and platelets, you might get more transfusion reactions or TRALI or ARDS, but that didn't appear to be the case. So what does this mean for Australia and New Zealand? Well, our guidelines, given that the overall conclusion was a non-statistically significant reduction in mortality, the Australian Red Cross have said, well, it's not statistically significant, so we should just, anything better than 2 to, or 1 to 1 to 2, or 2 to 1 to 1, depending on which way around you want to spin it. But essentially, slightly more red cells is okay, but try and get it closer to 1 to 1 to 1 where possible. And in Australia, for our blood products, that means 4 units of red cells, 2 units of FFP, and 1 unit of platelets is actually, or 1 bag of platelets, is the 2-1-1 ratio. So you have to get better than that. A 1 to 1 to 1 ratio in Australia would be 4 units of red cells, 4 FFP, and 2 platelets. So that would be, along the bottom of the screen, is probably the minimum that we need to aim for. What about just red blood cells themselves? Well, they're not the ideal resuscitation fluid, and I work for a helicopter service that does use just red cells in the field. But if you looked at the pure statistics, you would say, oh, I wouldn't use this as a resuscitation fluid with a lactate of 25 and a potassium of 25. But we do, and it's a bit like giving people albumin in ICU. It does give a fluid bolus that actually remains in the intravascular space. So I think that's largely where most of it helps. And there has been some research done in New South Wales where they looked at transfusion with red cells and survival in traumatic cardiac arrest, and they found that there was more survivors with red cell transfusion, which is probably along the lines of bolstering their intravascular volume. But it's a great selling point for services, and you'll see if you look at Twitter and type in red blood cell transfusion helicopters, there's hundreds of promotional things for services, particularly in the UK, that are promoting themselves as contemporary using red blood cells. And interestingly, in Queensland, I think I was just talking before that you guys are actually at the cutting edge of doing novel things and well moved beyond just giving red cells. And I think that's the way we're moving forward around Australia. What about plasma alone? So I talked briefly about the glycocalyx and things like that. There's a lot of animal research that says that if you give people plasma, you can restore the endothelial glycocalyx. In rat models, here you can, the second article, reduce pulmonary inflammation and hyperpermeability. And then the third one is reducing lactic acidosis and catabolism. So there's lots of potential benefits for using plasma. So, and how would it work? Well, it would reduce the glycocalyx shedding in the similar model than before. I could probably skip ahead here. So if the plasma might be good, the earlier we use it, the better probably. And I know in our emergency department, often we see people get 6 units of red cells before they get their first bag of FFP, and it's probably the wrong way around. But what about if we brought it way forward and we brought it into the pre-hospital space? So there's been two moderate-sized trials done recently looking at giving early plasma in the pre-hospital setting, either in isolation or with blood as well, or with packed red blood cells. So the combat trial was done with the EMS services, a very, very short scene time. So basically the patients had barely thawed the FFP from the fridge in the ambulance by the time they got to the ED. And then once they hit the ED major trauma centre, everything was ready to go. So it didn't show a difference in a system where there was very short transport times. The PAMPA trial was interesting in that that's actually has shown a 10% absolute reduction in mortality, which is enormous for clinical trials, almost unbelievable amount. using plasma and occasionally packed red blood cells as well in some of the cohorts. We're still waiting for that trial to be repeated in terms of the outcomes, because it's a staggering reduction in mortality. So watch this space for plasma. And there's a number of problems with the Pamper trial, but I think it's promising that plasma might be a good idea into the future. Particularly if you've got long transport times. So there's a secondary analysis of those two trials together and found that there was an improvement in the effect of plasma if you've got long transport times, which sort of makes sense, really. If a short transport time, you come to ED and you get plasma straight away anyway, well, it's not going to make a difference. But if you've got a long transport time, there's a good chance it probably does make a difference. This brings me to the next, probably the most controversial trial I'll talk about, the refill trial done in the UK. So this was done in the setting of many UK ambulance services and helicopter services not stocking blood products, and they were wondering, is it worthwhile? What's the bang for buck? Is it worth the effort of trying to put this into our service? And so this was a pre-hospital study only, looked at 2 units of red cells plus lysophilized plasma, which is freeze-dried plasma from Germany, versus a normal saline placebo. And they looked at this interesting composite endpoint that they used to try and reduce the overall sample size they needed, that looked at the lactate clearance as one outcome measure and also mortality. And they found no difference. So they found that if you gave patients with your helicopter service 2 units of red cells, 2 units of lysophilized plasma, which is sort of 1-to-1 ratio, versus a litre of normal saline, there was no difference in outcome, which threw the cat amongst the pigeons in the trauma research space. And I mean, there's a number of questions raised about this, and some of it might be short travel times to hospital again, and when they come to hospital, they get all those same products anyway. But it does provide some reassurance that as paramedics, if you're gone to a scene of a trauma, you've only got normal saline in your bag, and the patient's in profound shock with a blood pressure of 40 or 50, am I going to be doing harm by giving them a fluid bolus? Well, in the refill study, that's exactly what they did. They gave 400 mils, enrolled them in the trial, and then another litre, and they had no significant difference in outcome. So I think you can probably be reassured that 1.5 litres of normal saline, if you had to give it, by had to give it, I mean the patient's got a very low blood pressure and you really need to treat them. If you had to give it, well, it probably does no harm compared to giving them the whole shebang with the helicopter and the blood products and everything else. So I think that does provide some reassurance that optimising time to getting your time to hospital short is the most important. Giving it as little fluid as you need, but enough that the patient's not in profound shock, is also important. Interesting trial, probably a good trial for people to have a read of. What about cryoprecipitate? This is the other big trial that was published last year. So fibrinogen is the white lattice-like illustration in this picture that holds the red cells and the platelets together on the surface of the clot. And we know that fibrinogen levels fall in trauma from a combination of consumption and the hyperfibrinolysis process of acute traumatic coagulopathy. Here's another sort of illustration where you've got the clot containing red blood cells, fibrin mesh over the top, and platelets in the mix too, and it's all linked together with factor VIII and von Willebrand's factor. So all these things are very important. Now, cryoprecipitate has high levels of fibrinogen, high levels of factor VIII, and high levels of von Willebrand factor. So all of these components that are needed for the healthy clot are in cryoprecipitate. So maybe if we gave that early, we would be able to prevent further bleeding. So there's a feasibility study done. This is all very UK-centric research. Feasibility study done that said it was feasible to do, and then the Cryostat-2 was a large, very expensive trial done in the UK. Published in JAMA last year. It found, interestingly, I mean, the selling point is there's no difference between the two groups, whether you got early cryoprecipitate empirically, which is 6 grams, or you got it as part of your massive transfusion process. So the question is why is there no effect here? And I think the comparator group in this trial was early cryoprecipitate in the intervention arm, where you got it straight up front, versus what would be otherwise early cryoprecipitate in a massive transfusion process with very tight and rigorous transfusion labs looking at the fibrinogen level. So I think there probably wasn't a great separation between the two groups, and it certainly fibrinogen is important in the whole process, but whether it's delivered early up front versus as part of your normal massive transfusion protocol probably doesn't make a difference. But again, a very important trial. And in our hospital, we actually, before this could come out, the evidence was so compelling that we brought cryoprecipitate right forward, and we actually gave cryo up front with our first bag of massive transfusion, which we will have to revise as a result of this trial, potentially. What about whole blood? Why not whole blood? Well, whole blood seems to make sense to me. It's been done historically since the very start of blood transfusion, and cold stored fresh whole blood is actually very good at doing its job. So this was a sort of a survey of units that are using whole blood, and most people are using low titer, so low anti-A, anti-B antibodies, group O whole blood. So that's like when you give a plasma transfusion, you give AB plasma, which doesn't have any antibodies in it. This is close to that, and it's what's been used throughout the world for all of the major wars and everything else as well. So it's generally fairly safe to use, or not, it is safe to use. Mostly leukodepleted stocks is what people are using, and it's becoming widespread, including in US, Northern Europe, parts of the UK, including air ambulance services as well. Most services are doing 8 units and then moving to component therapy, and helicopter services using between 2 and 4 units. It's really gone full circle with whole blood. This is what blood transfusion started with, and then in the wars you had your walking blood bank, and then we had an improvement in technology in the 70s where component therapy was possible, and blood banks thought, well, if we can separate it out, it's a valuable resource. We can get the most bang for buck by separating out the products and using them only when necessary. And then more recently in Iraq and Afghanistan, they've started looking back at whole blood again and found it actually probably does a better job in preventing clotting problems than component therapy. So why might it be best? Well, in component therapy, you have a much larger number of different packets of things, different storage temperatures that you need them to be at, and you have 3 times the amount of anticoagulants and additives involved, so a much larger volume. So it's less potent. Whole blood, on the other hand, you have lots of active platelets, so the platelet function is a lot better. Coagulation factors are at 100% rather than 65%. Much higher red cell concentration, and one storage mode. So you just put all 4 bags in a 4-degree fridge and you're done. So for pre-hospital services, it makes a lot more sense. Whereas normally component therapy, platelets have to be room temperature, FFP has to be frozen, there's all sorts of complicating things. So, and there's some evolving evidence, so observational trials that look at different variables and do multivariable logistic regression analyses to try and work out what affects what, have found that the low titer O negative blood is actually associated with improved survival overall and no organ dysfunction or transfusion reactions. So it's obviously, watch this space because I think it's going to come, whole blood, certainly. I had another slide. Yeah, certainly the whole blood in the Australian setting, and I don't know about New Zealand, but I think it's the same as well. It's not collected by the Australian Red Cross Blood Bank. We collect the blood, split it all into components straight away, and there's no whole blood available even if you wanted to use it. So for services in Australia to do it, they either have to collect the blood themselves, which would be very difficult to do, or we have to lobby for Australian Red Cross to actually start producing whole blood specifically for trauma and for other reasons as well. TXA, so I might have skipped. So obviously there's adjuncts. I was just talking about adjunctive treatment in hemostasis now. So calcium is important. I won't dwell on that very much, but when you transfuse packed red blood cells, they have no calcium in the bag and a chelating agent to reduce that. So when you then give that to the patient, their calcium level drops. So, and calcium is important for cardiac activity, but also for coagulation. So it's very important that at least 1 ampule to 2 ampules of calcium goes in before your calcium levels drop. And there's been a few studies saying, look, you should actually give it early before the first 4 units rather than waiting for it to drop and then treat. Second thing is TXA. So hands up if your service was involved in the patch trial. Okay, a few, not heaps. So there's there's a big Australian study done, and it's largely done in response to CRASH 2 study that looked at tranexamic acid in a developing nation setting with limited trauma operating and limited intensive care and limited screening for complications. So the patch trial looked at the ANZ setting and, oh, there we go, backwards to front. And it was very much a pragmatic study where we used a double-blind placebo-controlled trial of sealed envelopes with either tranexamic acid or placebo in them. And we investigated, does TXA improve functional recovery in 6 months in severely bleeding patients in developed nations. We tried to find patients that were very sick, and we tried to find patients that were at risk of acute traumatic coagulopathy. So we used the COAST score to try and find a high proportion of patients that were at risk of having a coagulopathy. And it was about 25% in the trial, so that was actually reasonably good at determining that. But the outcome of it was interesting. So very much like the paramedic trial in cardiac arrest with adrenaline, we found when we use an outcome measure of that's dichotomized to either favourable functional outcome or unfavourable functional outcome, we found no difference between the two groups of TXA versus placebo, but we found a improved mortality in the TXA group and worse mortality in the placebo group, which makes you think, well, you might be using the treatment, but you're producing more survivors that have a poor quality of life. So that is concerning. And that's not what we would want to achieve, but it's also difficult to withhold a treatment that you know improves mortality just because some of those survivors may not do very well, because on an individual patient basis, you might be depriving someone of surviving who has a pelvic fracture that then means that they're disabled but can't actually function very well. So they're not all neurological problems. All the disability is not all neurological. So I think what we need to, where is TXA up to now? Look, I think overwhelmingly it's been adopted internationally, and Australia's a bit of a standout in not using TXA frequently. So I think eventually it's going to make its way into the pre-hospital setting, and I think it's probably a good thing, and I don't think we're going to get another trial to prove it yes or no in terms of TXA. And I think it probably will, if we use it in the most severely injured patients and patients whose outcomes not predetermined by their brain injury, which is what's sort of driving some of this, we think it's probably going to be helpful rather than harmful. Okay, so just a couple of things to finish. So who's heard of viscoelastic testing for coagulation problems? So essentially what this is ROTEM or TEG technology. And basically it takes a whole blood sample, so just fresh whole blood, puts in a cup, puts a pin into the cup, and then rotates the cup with the pin in it until a clot forms, and measures how long does it take the clot to form and how firm is the clot, how much resistance to turning is there. So the technology has been around for a long time, and it's been used in cardiothoracic surgery quite a lot because when they're operating, they're constantly diluting the blood and they're using heparin and all sorts of stuff. So they need to know in real time what's happening with the coagulation, so they know how much protamine to give and all this sort of stuff. So they found that TEG was very useful, and it reduced the amount of transfusions that they needed in theatre, because they weren't having to do empirical transfusions, they could just transfuse as necessary based upon TEG or ROTEM. So what the TEG gives you is a clot profile, which is, I suppose, this is resistance to the twisting of the cup over time, and as it gets fatter and fatter, there's higher resistance. So you can see different pathologies have different shapes in terms of their TEG or ROTEM, with normal being up the top, anticoagulation, long time to start the clot, but then a normal clot strength. Fibrinolysis being you form a clot, but then the clot gets lysed over time. And then down the bottom, probably hypocoagulable state, sort of similar to trauma, very low amplitude, so low clot firmness and a fair bit of delay to forming the clot. And you can use this TEG pattern to determine your management of their coagulopathy. If there's low amplitude or low firmness of the clot, you can give platelets or fibrinogen. If it takes a long time to start the clot, you can give clotting factors. So you can develop algorithms based upon the TEG. And then this is the one from Gold Coast University Hospital, which is again a very early adopter of ROTEM technology in their ICU and trauma services. So we found in massive transfusion it does reduce the amount of blood that you need to use. In trauma, it has a good basis for why it might help, and it's actually got a grade 1C recommendation in the European guidelines. And so it was the right time for a clinical trial to come out about this. And so they did do a clinical trial on this, called the ITACTIC trial in 2020. And it looked at, if you use the TEG, are you going to improve your overall survival? And this is another example of a clinical trial almost trying to run before it can walk. So it's taken centres that don't really use TEG, given them an algorithm and said, dichotomously, you must use TEG or you mustn't use TEG. But in the setting of all of that, you've also got to give a 1-to-1-to-1 ratio transfusion for all these patients. So all the patients got 1-to-1-to-1, and the only reason they used the viscoelastic testing was to determine how much fibrinogen to give. And so it wasn't really do a viscoelastic test, then decide what products to give. It was a give everything and then just decide about the fibrinogen with the TEG. So this was, again, a negative trial. But I think what we need to do is to have more trials based around actually using the technology to its full potential in a single centre and really defining whether it actually works before you do your large randomised controlled trial. And so TEG is still the jury's out on whether it's going to be useful or not. All right, last few minutes, let's talk about the future, some unanswered questions. Unfortunately, the talk probably raises more questions than it answers, and that's probably just the nature of the research. But it is an interesting space to be working in, for sure. So keep your eye on the journals and have a read of the massive transfusion guidelines from the National Blood Authority as well. But the immediate future, will Reboa remain a therapeutic option? Well, I think it probably will, particularly in larger centres, even in Australia. Will plasma become more available and used pre-hospital? Well, I think it will, and it sounds like in Queensland it already is starting to be. The plans are afoot to use lyophilized plasma in the pre-hospital setting. Will TXA become standard practice? Well, I reckon we will see that in the not too distant future, but and I don't reckon we'll see another study on it for a long time. So someone's going to have to make a decision in terms of the medical directors of the ambulance service whether we use it or not. Will we see whole blood? Well, I think that's something that we definitely will see in the near future in Australia, and it's just a matter of the Australian Red Cross coming to the party. But there's lots of scope for research on that as well. And will some of the existing dogma and key management issues be challenged in randomised trials? So this is things like permissive hypotension. This is things like should we permit permissive hypertension? There's certainly no clinical trials of whether it's actually a safe procedure to do. And I think really should only be for arterial bleeding when you know it's happening and for as short a period of time as possible. And that's the guidelines from Australia. And then I'll probably finish on this actually just for fun. What we haven't really asked is what's more hard. So for your paramedics here who are treating in the field and in the sort of the HEM services as well, what's better? Do we permit hypertension? Do we give vasopressors? Or do we give normal saline? And I think it's going to be a tough choice. I think like most intensive care intensivists, a little bit of everything is probably the best. Normalise things where you can. So I think we want to avoid shock from permissive hypotension because we know that's the pathophysiology of acute traumatic coagulopathy and vascular failure is prolonged shock. So we can't really allow that. We know there's a vasoplegic component to, particularly late after the first couple of hours, there's a significant vasoplegic component to trauma as well. So vasopressors probably have a role, particularly if you're doing secondary transfers. And we know normal saline's probably not terrible if it's used in small amounts if you have to. So I think a little bit of everything is probably okay. But watch this space because I think whole blood and TXA and a few other things are coming your way pretty soon. So thanks.
Thank you very much, Michael. If anyone has any questions, he'll be hanging around here for a couple of minutes. Yep. Awesome. So that draws a close to our night 2 of interactive sessions. For those who haven't had an opportunity yet to log into your Mesh portal, that is where you can find recordings of the presentations from this week. Due to the Wi-Fi issues at the resort, there is a little bit of delay in uploading them, but by the end of the week, all presentations will be up there, and that's also where you can download your certificate of attendance come Saturday. Enjoy the day tomorrow. Make sure you put that extra layer on. It will be a little bit cold out there. If anyone has any questions, come see Dylan and myself. Otherwise, have a great night. We'll see you here tomorrow afternoon.
Yeah, I hope it wasn't too. I can't do comedy, so like.
No, I still do comedy. So. No, it was awesome, man.
But it was pretty content heavy. But yeah, I think.
Oh, it was great. I think.
Yeah.
Like the relevance for all.